This is my introduction. By profession, I'm a clinical oncologist, and I did my PhD in cancer medicine, so that's my interest too. So I'll be talking about the principles of cancer management. And these are the topics which I will go through. I will try to complete them. I was told that tomorrow is holiday, so I will try to squeeze them in 3 days, or I might take another after next week. So there are a few things which I must clear. I will be talking about the principles of different things which are involved in management of cancer. And if you go to the literature, you might come across very advanced things. So in oncology, things change every day, and so I will try to highlight where I am very basic and where advancement has been taking place. So first, I will give you an overview of the oncology principle of management, and then I will take each modality one by one. In brief, the modalities are divided into local and systemic. Local modalities are surgery and radiation therapy, while systemic therapy, they are chemotherapy, endocrine therapy, targeted therapy, then immunotherapy, personalized treatment, human agnostic therapy, and best supportive care. And in that, I will try to take this development of new anti-cancer drugs and clinical trials. So if you see, surgery has half of that share. In almost all conditions, surgery is the main modality. And next is as radiation therapy. While systemic therapy has only 10-11% share, but that is more important than other tools. Now, some fact about the oncology: it is an investigational and evolving field. There is no definite treatment for any cancer, but standard of care. Unlike other disciplines like cardiology and gastroenterology, we have PET prescriptions. So if you go to 10 consultants, they will write the same thing or similar to that. But in oncology, things change very quickly, and oncologists, they have different views and different approaches. Then all discoveries and inventions, they are tested in clinical trials for validation, and the interim and final results, they are published and presented in international conferences like ESCO and ESMO. ESCO is American and ESMO is European, where they are where they are critically analyzed, and when they have a consensus, and they will issue guidelines which are published, and they are made available to clinicians. If there is any new recommendation, that is always evidence-based, and that becomes a standard of care. That will supersede the previous one. For a particular case, treatment is preferably planned in tumor boards or multidisciplinary teams. In simple words, when patient comes, we take history, do examination, do necessary investigations, and in oncology, biopsy is the main. As long as you don't perform the biopsy and confirm the diagnosis, you cannot treat. Legally, it is important. And after that, to oncologists, most of the time patients are referred by surgeons or other physicians. So when they reach to oncologist, then he will try to do the staging. Staging means what is the extent of tumor within the body, whether it is in early stage or in advanced stage. Once that is done, then he will analyze the information available to know the prognostic factors and predictive factors. Prognostic factor that will tell us what will be the outcome of how the tumor will behave, and the predictive factor that will tell us what will be the outcome of treatment which are being planned. Then after having all this information, nowadays it is mandatory to discuss each case in tumor board meetings. Every institution has got tumor board, which involves surgeons who are expert in oncological surgeries, radiation oncologist, medical oncologist, then social welfare officer, and other supportive team members. In the meeting, they discuss all aspects of that disease, that particular tumor, and they plan the treatment, how to go about, whether it should be the surgery first or the chemotherapy first, whether radiation is required or not required. What is the sequence of treatment? Right? Now, the simple definition of cancer is that it is a genetic disorder which develops from clonal expansion of single transformed cells with a accumulation of molecular alterations in the genome. It is characterized by unregulated cell growth, invasiveness, and metastasis. Cancer comprises a heterogeneous population of cells which include cancer stem cells which are responsible for sustaining the growth. Now, any tumor that comprises of cancer cells, inflammatory cells, blood vessels, and stromal cells like cancer-associated fibroblasts. And this is seen whether it is primary tumor or it is locally advanced or it has metastasized. Metastasized means it has spread to other sites. So everywhere they have got all these elements of, they will have these cellular elements. Now, I am not. Have you gone through this hallmark of cancer? लोग शायद नहीं करवाया. No. So I will strongly recommend you to go through this paper. It is published, I think, April or May, in Journal of Cell, and it is a synopsis of all the research which has taken place until now, and it has suggested many things for future research and treatment modalities. So according to this, there are 9 hallmarks of cancer. These hallmarks are the capabilities which cancer cells they acquire during embryogenesis and their evolution. So, not these 9 hallmarks, they are not operative in all cancer or always. Maybe some of them are operative in one type of cancer, in another type of cancer, one or more. So, in simple words, the first one is sustaining the proliferative capability. Means they become autonomous and they keep the proliferative activity. They become independent of programmed cell death, of apoptosis. So they are no longer under control of inhibitory factors. Third is inducing new vasculature, means they are capable of inducing new blood vessels formation to sustain with the oxygen supply, nutrients, and other factors. Another is the cells are phenotypically plastic, means they can change their character. They can de-differentiate to the primitive one, or they can differentiate into another type of cancer. For example, they can epithelial cell can be changed itself to mesenchymal cell. Then activating invasion and metastasis. This is the ultimate characteristic. The tumor will lose its primary site and it will spread to distant sites. They are capable of evading immune system. They become independent. Then deregulation of cellular metabolism. In cancer, normally energy required through citric acid cycle, I think 34 or 36 molecules are obtained, but in this acquires the capability of aortic glycolysis, which gives you only 2 molecules of ATP. So there is increased demand for glucose, and I will tell you when talking about the PET scanning. So advantage is taken for this property. This stable replicative immortality. Every cell normally has got a limited, it can divide to a limited time, but these cancer cells, they become independent, and there is a biological clock in the telomere, and the cells can divide indefinitely. So the last one is they become independent of tumor suppressing factors. So I advise you to go through this to know more and in detail. So according to this, there are 9 acquired functional capabilities or hallmark of cancer, which I just named. And besides that, there are 5 hallmark enabling phenotypic characteristics. In addition to that, they have identified 7 classes of hallmark facilitating cells in tumor microenvironment. And additionally, there are a number of hallmark influencing factors, including age and obesity. So this is a paper which covers all aspects of cancer and cancer biology. These are 5 phenotypic characteristics, enabling phenotypic characteristics that include these microbiomes, tumor-promoting inflammation, non-mutational epigenetic influence, loss of genomic integrity. So according to this, about 750 different genes they are involved in carcinogenesis. These tumors, they also have innervation. The nerve endings, they form synaptic connections with tumor cells, and nervous system also have influence. And microbiomes, polymorphic microbiomes, they are in different sites of the body. They have interaction with these tumor cells and vice versa. So they all influence each other. These are the hormone-conveying cells in the tumor microenvironment. These include cancer cells, cancer-associated fibroblasts, neuronal cells, immune cells, macrophage, neutrophils, and senescent cells. Senescent cells means those cells which are incapable of dividing, cell division, but they do release signals to influence surrounding cells. So according to this, they have devised the model as a 4-dimensional. The first dimension is the 9 hallmarks. Second is the hallmark conveying cells of tumor microenvironment. And another is enabling phenotypic characteristics. And then all these are influenced by systemic interaction. So now we consider cancer is a systemic disease, not a localized disease. Now, something about epidemiology. This is the second commonest cancer after heart disease, This is the second commonest cause of death after heart disease. Lung and female breast cancer, they are the leading one. Until Block 10 that provide this information as statistics. In 2022 edition, breast cancer was the leading cancer among both sexes. But this time, lung has taken over and breast cancer is very close to that. Incidence is increasing and decreasing in high-income countries, while it is increasing in middle-income ones. In South Central Asia, where we are located, Pakistan, India, Bangladesh, incidence has rapidly increased, mainly due to adopting lifestyle of high-income countries. For example, delayed conceiving, they want to have fewer children, obesity, physical inactivity, increased awareness, and better screening facilities. There is increased awareness and increased diagnosis of cancer. Briefly, cancer is diagnosed in 3 ways. Either it will be incidentally or on screening, and third, when patients develop the disease and present with signs and symptoms. Incidentally means patient goes to the doctor for something, and while examining they come across that he or she has got a tumor. Cancer is painless to start with, right? That is important. So when it is advanced and it is compressing nerves or other structures, only then it causes symptoms in patient. So incidentally, that is one way. Second is on screening. Now, screening programs are available, and people are strongly advised to follow that. Mainly breast cancer, cervical cancer, and colorectal cancer. These are the 3 established screening programs. But people I've seen that if you go to their clinic, they are willing to screen liver cancer and other type of cancer, but they are not established programs. Screening programs are kept for only those cancers which qualify 3 conditions. One, the cancer is common. Second, there are treatment facilities available. And third, there are assays or tests which are easily available and economical. For example, in breast cancer screening, all we need is just patient's clinical examination. Second, second is ultrasound, or if there is any suspicion in ultrasound, then the mammogram. In cervical cancer, you just need a smear and make a slide and just examine under the microscope. In colorectal cancer, we do the stool testing for presence of any occult blood. If that is positive, then we advise patient to undergo endoscopy. So these are the 3 established programs. Breast cancer is usually advised in UK after 50, in America it is 40. In our country it varies because in our region breast cancer incidence higher than other Europe or America. I will show you the data. So we advise 35 or 40. That is the right age to go for screening. Colorectal cancer after 50 and cervical cancer after 21. Then patient can present with signs and symptoms. He or she can present with signs and symptoms of primary cancer, primary lesion, means she can present with. In my talk, I will be giving you example of breast cancer, right? Because that is common and easy to explain. Patient can present with lump in the breast. or she can present in advanced state with signs and symptoms of metastasis. Means the tumor has gone into the bones and she has pain in the legs or in those bony areas, or fracture. It can go to the lungs. It can cause a cough or something like that. It can metastasize to brain. It will give you peculiar symptoms. Or some cancers, they release hormones and they cause paraneoplastic syndrome. And these paraneoplastic syndrome, it has been seen that they appear at least 5 years before clinical diagnosis of the cancer. So, after diagnosis, we manage cancer, we manage the disease using multidisciplinary approach, as I told you, the tumor board. The cancers are incurable, but significant improvement has been seen in improving the quality of life, progression-free survival, and overall survival. But it is very expensive, especially nowadays. For the last 10 years, since the start of this immunotherapy, I'll be discussing later, the cost is very high. For treatment of cancer, one must know the natural history of breast cancer or its variants, natural history of lung cancer or its variants, because they behave differently. So if you know the natural history of cancer, then it will be easier to manage. For example, if triple negative breast cancer is diagnosed, triple negative means estrogen receptor negative, progesterone receptor negative, and HER2 receptor negative. It is a very aggressive type of cancer. So we will plan treatment accordingly. So this figure shows start of these are the normal cells. If there is any insult, there will be changes, DNA damage. So the repair mechanism will come into action and it will revert to normal cells. If not, then either it will undergo apoptosis or it will be transformed. Once transformed, that is irreversible, and under favorable condition, it will progress and become cancer. We call it cancer when it invades the basement membrane. Until that, it is pre-cancer condition. So once the basement membrane is invaded, it is cancer, and the cells can grow outside the primary site. We call it locally aggressive, locally advanced, or if through lymphatics and blood vessels it metastasizes to distant organs, then we call it metastatic. So this is important to understand. It takes only 30 doublings to acquire the size of 1 gram. 1 gram means 1 billion 10 raised power 9 cells. That will give a size of 1 gram. This is the size which can be detected clinically on imaging, like on CT scan. We can see a lesion of that size. And then it takes only 10 more divisions or 10 more doublings to acquire the size of 1 kilogram. And 1 kilogram is not compatible with life. So this is the window we have got to manage. So this is a preclinical stage. This doubling time that range from 9 hours to 43 hours based on the G1 phase. And shorter the doubling time, the more aggressive is the tumor. Some more information. This genetic landscape from transformation to metastasis, it involves a number of molecular alterations that accumulate within genome. It has been seen that 193 oncogenes and 143 tumor suppressor genes, they are involved. they have been identified, and they are KRAS, PI3K, and P53. They are the genes which are seen involved in most of the cancers. Unique variants are being identified in different cancers. Cancer type-specific DNA alterations represent highly sensitive biomarker for screening, diagnosis, prognosis, and treatment. So these alterations in the genome, if they are identified, characterized, and if we found that they are actionable, we use them for diagnostic purposes, for treatment, and they are also helpful in screening and monitoring the follow-up. Analysis of multiple cancer genomes is identified new biomarkers and their pharmacological exploration, resulting in new management approaches. This is the same thing which I just. So I'll show you few pictures of many people. They said they have never seen cancer. This is the cancer of tongue. This is very common in our country because of the palm gutka things. It usually arises on the lateral border of the tongue. On right side, this is again cancer of the oral cavity. The bone is destroyed. This is the lump of lymph nodes. On each side, about 200 lymph nodes are present. So if they are enlarged, so this is the lymphoma. It is a tumor of hemopoietic system. Breast cancer, it can present in different sizes of breast. It can appear as a lump which is visible and with nipple retracted. It can present with this Paget's disease, we call it. It is a disease, a tumor which has involved the nipple and the areola, which is destroyed. Or it can present in this form, advanced. And this is an inflammatory type of breast cancer. What happens that the blood tumor cells, they invade the blood lymphatics, and they accumulate in the skin. Skin becomes very thick. In inflammatory cancer, it is not necessary to have lump if you examine. So it is an aggressive type of cancer. These two figures, this is the middle finger and this is the toe. The differential diagnosis include arthritis. Initially we can see that it is arthritis. In this case, X-ray was done and you can see there is no bone in the terminal phalanx. In the toe there was no bone, all destroyed. So this was a metastasis from lung cancer. So it was non-small cell type of lung cancer. On the left side it is a rectum, endoscopy was done, and this is how it appears normally. But if the tumor is there, this is the tumor which is totally blocking. On the right side is the sigmoid node, large intestine. Same, this is a normal and this is a tumor inside. So endoscopy is done and we diagnose and we take a sample for biopsy. This is the urinary bladder. After resection, this is urinary bladder which has been opened and the tumor, you can see the tumor inside. This is ovarian cancer. It is presented as a cyst. And you can see they are the tumors which are on the surface. The same ovary has a tendency to spread in the abdominal cavity. In the abdominal cavity there is a structure called fatty tissue which is called omentum. So that is a favorite site for ovarian cancer to go and grow there. So when we do surgery, we make sure that this has been removed. This is endometrial cancer, cancer of the uterus, which is open after surgery. It is split into half. You can see the whole tumor is occupying that. So this is interesting. We do come across cancer during pregnancy. Patients, they come to antenatal clinic, and when they are when the clinician starts following up, so they come across this is cervical cancer. You can see over here. So it is a different subject. It is not uncommon to have cancer, different type of cancer, during or along with pregnancy. Briefly, if this is diagnosed, we don't do anything in the first 3 months, because first 3 months they are sensitive, so we don't expose the patient on drugs or other things. In second trimester, we can consider doing surgery or any other intervention. If possible, we never advise to terminate pregnancy, no. So we let the pregnancy complete, and after delivery, we treat the patient. This is T-cell lymphoma. You can see the tumor has they have infiltrated the skin, and in the blood these tumor cells they circulate. So this particular picture, that is called Sézary syndrome. This is melanoma, skin of the cancer. It's a very aggressive type of cancer. Now, here is a situation where a patient presents, say, there is a swelling in the neck and or anywhere in the body. If that will be removed for histopathological diagnosis, and surprisingly, the report says that it is adenocarcinoma. Now, what is doing adenocarcinoma doing in the neck? In the neck, normally the lymph nodes are there. So the clinician will try to find the primary tumor. So that is metastatic, through which the patient has presented. Now our job is to find the primary. Where is the primary? From where it has come? We normally do. We take the key. We examine the patient, do certain tests, and try to reach or find out the primary site. But in such cases, we don't come across any primary, and we label it as metastatic carcinoma of unknown primary or unknown origin. So the philosophy is that, in simple terms, if the patient is male and you understand the diaphragm, it is a diaphragm which is a partition between thorax and abdomen. If it is above that, it is most likely from lung cancer. Right? And if it is female, it is from breast cancer. If it is below the diaphragm, in male, we take it as from prostate cancer. In case of female, ovarian cancer. Because these 4 cancers, they are the most common. So in such situation, where we don't know the primary, we will empirically treat the patient considering these tumors. Because as long as you don't know the histopathology and exact diagnosis, there is no point of starting treatment. So there are different classifications of cancer. It can be pediatric, age, according to age group, it may be pediatric or adult. The good thing with the pediatric cancers are that they are potentially curable. They are very sensitive to chemotherapy. While in adults, they respond differently. Morphologically, cancer may be epithelial or mesenchymal, hematological, or of immune system. Epithelial are the most common, they are 85%, they are called carcinoma. If they arise from mesenchymal tissue, they are sarcoma. Hematological example is the leukemia and lymphoma. Lymphoma basically it is immune system and hematology are one and the same thing. Others include central nervous system tumor, germ cell tumor, primitive neuroectodermal tumor, melanoma, carcinoma, they are rare. Then molecular classification. This is important because nowadays because we have got good tools. We do classify each tumor at molecular level and consider while planning treatment. GlobeCan is a WHO body which published data from the whole world, I think about 185 countries, and considering 36 types of cancer. So this was published in 24. According to this, in both genders, lung cancer is the most common cancer, followed by breast cancer, then colorectal. And the mortality wise, lung cancer is at the top of causing death, followed by colorectal and liver. Among males worldwide, lung cancer is the leading cancer, followed by prostate and colorectal. And the mortality among male, lung cancer is at the top, followed by colorectal and liver cancer. Among women, breast cancer is the leading cancer, followed by lung cancer, and then colorectal, thyroid, and cervical endometrial. And mortality-wise, breast cancer is the leading cause, followed by lung cancer. The data about Pakistan, according to that, lung cancer is the leading, followed by breast and then colorectal. They are more or less similar. Mortality-wise, breast cancer is the leading cause in both genders, followed by lung cancer, liver cancer, colorectal. I will provide you copies of this presentation, right? So you don't have to write them. Among males in Pakistan, prostate cancer is the leading one, followed by urinary bladder, colorectal, lung, non-Hodgkin lymphoma, lip and oral cavity. Just remember this, it is number 6, according to this data. In reality, it is the number 1. So mortality-wise, lung cancer is at the top, followed by prostate and liver. Among women, you can see almost half of all cancers are breast cancer. So 44%. Thereafter, cancer of the uterus. Mortality-wise, breast is at the top, followed by ovarian cancer and colorectal. I will skip this. This is a paper which is published in 23. According to that, it is an observational study. Breast is both, because breast cancer is also found in among men, though it is rare, but it is not uncommon. It is rare, about 2 to 3%, but they do develop breast cancer, and they are aggressive. So at the top is the breast cancer, followed by oral cavity cancer, then colorectal cancer, then liver cancer and gallbladder cancer. Lung cancer comes at 5th position. This is a study conducted by Karachi Cancer Registry. It was also published in 23, and this is age standardized study. And according to this, if you see, among women, breast cancer is at the top. After that is the oral cavity cancer. Then is the ovarian cancer. And among men, this oral cavity cancer, that is at the top, followed by liver cancer. I would suggest that this is the real picture which we are facing. That among women, breast cancer, and among men, oral cavity cancer because of this arm, gutka, things like that. And liver cancer is very common. This is in children, leukemia, brain tumors, bone tumors is the pediatric side of. Now, what are the risk factors? ionizing radiation and asbestos. They are the physical agents. Among chemical agents is tobacco, gutkha, naswar, polycyclic hydrocarbons and other chemicals. So tobacco is the most important in this. Then is the infections. Now, hepatitis B virus, hepatitis C virus, human papilloma virus, Epstein B virus. Then this is bacteria Helicobacter pylori and schistosomiasis. Now, hepatitis B and C, they are involved in liver cancer, and human papilloma virus is responsible for cervical cancer and nasopharyngeal cancer. Epstein B virus, that causes lymphomas. Helicobacter pylori, it causes stomach cancer. When I say causes, means they are involved. Schistosomiasis, it causes urinary bladder cancer. Now, lifestyle is also important. Obesity, it plays an important role. Obesity and physical inactivity. Then is the alcohol, and the protective side is dietary fiber, vitamin A, C, and E. They are protective. Stress. It has been seen that stress is also a risk factor. How it works? It depresses the immune system. And so whatever immune system is trying to protect cells from developing cancer, it further reduces that protection. But it has not been established. Endocrine factors, estrogen and testosterone. Estrogen is a established cause of cancer in breast, uterine and ovarian cancer, while testosterone in prostate cancer. There are certain syndromes, genetic syndromes, which are associated with cancer. One is Lynch syndrome. Second one important is hereditary breast ovarian syndrome. I will discuss that. Now, there is a study which is published earlier this year in Nature Medicine, where in 200 countries, 36 different types of cancers were studied, and they found that 40% of the cancers, they can be prevented if we stop tobacco, control infection, especially hepatitis B, human papilloma virus, and Helicobacter pylori, and alcohol. So if you just control these three things, you can reduce the cancer burden by half, almost 40%. So this is an important study. What is Lynch syndrome? It is an autosomal dominant inherited cancer susceptibility syndrome, which is characterized by familial clusters developing various cancer at an early age group. In this, in a younger age group, colorectal cancer, that is 50% of the cases, endometrial 40%, and ovarian. So, in families, younger age group, and these three cancers, they are developed, there is risk of development, it is Lynch syndrome. These are the genes which are involved. Breast ovarian syndrome, and there is germline mutation which is characterized by loss of heterozygosity of wild-type BRCA allele with increased risk of breast and ovarian cancer. It is seen in about 10% cases. Now, so the BRCA1 and BRCA2 genes. In breast cancer, there is 85% lifetime risk. Normally, the age group for breast cancer, if there is a BRCA mutation, it will develop at an earlier age. For BRCA2 mutation, it has 60% of lifetime risk. In ovarian cancer, the BRCA1 mutation has 40% lifetime risk, and BRCA2 20%. So this BRCA genes that is also seen involved in prostate cancer and pancreatic cancer. Ashkenazi Jews, they are at higher risk with mutation of BRCA1 and BRCA2, and they cause prostate cancer. In pancreatic cancer, BRCA2 has been seen involved. with a risk of 5% or up to 5%. If you see in breast cancer, if the tumor is if patient come across and the tumor is hormone receptor positive, in 5% cases one should suspect BRCA mutation. In triple negative breast cancer, triple negative, ER/PR negative, and HER2 negative. So that is the aggressive form of cancer. In this 20% cases, BRCA is mutated. Now, breast and ovarian cancer, they should be suspected in progeny of. आपके पास पेशेंट आता है, आप सस्पेक्ट करें, अब टेस्ट वगैरह तो इजीली अवेलेबल नहीं है. ये जो इंटर मैरिजेस होती हैं, कंsanguineous मैरिजेस जो फैमिलीज में होती हैं, वो सिचुएशन है. और देयर इज अर्ली ऑनसेट कैंसर. अगर 40 से पहले कैंसर हो तो आप सस्पेक्ट करें यहाँ पर ये इन्वॉल्व है. और इन ओवेरियन कैंसर पेशेंट, ओवेरियन कैंसर में अगर आए तो आप सस्पेक्ट करें ये इस BRCA is involved. Now, there are two terminology: familiar cancer and hereditary cancer. They just remember the difference. Familiar cancer is defined when a person has 2 or more first or second degree relative with cancer. That is familiar cancer. And hereditary cancer is defined when there is history of multiple cancers in multiple generations of a person's family. I discussed how it is diagnosed. This is a list of different parameter classes. I won't go into them. Now screening. We start here from 30-35 age. In Europe it is 50. In America it is 50 age when they start, and it is done every 3 years. If everything is okay, every 3 years. If there is the diagnosis and there is suspicion, then every year. So this is mammography which is done. It is form of low energy X-ray of breast. So we do the clinical examination, ultrasound, and if required, then mammography. Cervical pap smear is done, colorectal, fecal immunochemical test is done, and if that is positive, then the colonoscopy. So this is a mammogram. It is reported in the form of bi-red grading. This is bi-red grade 2. It is considered benign, not carcinoma. But on the right side is bi-red 5. You can see there is a well-defined tumor with spikes coming out, and the nipple is retracted. This is a classic feature of cancer. So this is cancer, this is not. These are bi-red categories. I won't go into that. So after history examination and imaging of relevant site, we need tissue diagnosis, which should be confirmatory. There are different types. One is fine needle aspiration, cytology. FNA इसको कहते हैं आमतौर पर. What do? We just take a syringe, insert the needle into the tumor. That can be done only for those tumors which are accessible. And we just take the cells, put it on the slide, and examine under the microscope. It will tell you only whether it is malignant or not. It will not give any other information because there is no architecture preserved. But in core needle biopsy, in this thicker needle is inserted and the core of the tissue is removed, and that is stained hematoxylin, eosine hematoxylin, and that is examined. It will give you a complete picture, and one can also perform different molecular assays on it. There is a excision biopsy when you take the whole cancer, or incisional biopsy means when you are unable, the cancer is so advanced that you are unable to remove it, and for diagnosis purpose, you just take a sample, that is incisional biopsy. Sentinel node biopsy as a part of workup, I will come to it later, and liquid biopsy. Now, liquid biopsy is being done in selective centers in America and Europe, not everywhere. In this, you just take the blood and then you look for circulating tumor DNA or similar markers. Sentinel node, by definition, means the first lymph node which receives the lymph of a tissue. For the breast, all lymph is drained into the axillary lymph nodes. Now, what is the workup? We have diagnosed the cancer. Now, we need to do the staging. It will tell us what is the cancer burden in the body. We will also get biological profiling of the tumor, molecular classification. We will get information about behavior of the cancer, prognostic factors, and predictive factor outcome of the therapy. Then genomic profiling. When I discuss this tumor agnostic therapy, this is the latest thing which is in oncology. I will come back. Third lecture. Then comorbidity. While treating, we have to consider whether the patient is fit for treatment or not, because the chemotherapy is aggressive and with so many side effects, toxic effects. So, any comorbidity, especially heart problems, we have to consider that and before planning any treatment. Then the performance status means whether the patient can tolerate treatment that we are trying to plan. We divide it into 5 grades, 5 categories: 0, 1, 2, and 3, 4. Up to 2 means, category 2 means the patient is having symptoms but he is capable of self-care. If it is more than 2, means he is bedridden and he cannot take care of it, there is no point of planning aggressive treatment. Then we plan only palliative treatment. Nowadays the staging is done, they combine both anatomical and molecular markers. So that is called hybrid staging. The system which we follow is the TNM staging. T stands for tumor, N for lymph node, and N for metastasis. Because staging is used for gynecological cancer. In simple form, T means size of the tumor. Right? What is the size of primary tumor? If it cannot be evaluated or there is no evidence of primary tumor, or there is carcinoma in situ, is TIS. So this is the real one. T1 means, in breast cancer, T1 means up to 2 centimeter size. T2 means 2 to 5 centimeter size. T3 more than 5 centimeter size. And T4 when it involves the adjacent structures. Lymph nodes N1 to N3. Metastasis M0 means no distant metastasis, M1 means distant metastasis. So these are just an example of cervical cancer staging. This is of endometrial staging. This endometrial staging with molecular classification. If you see in the first early stage of cancer, when the tumor is confined to the uterus, they have included this molecular. OL mutation or P53 mutation. This is how it is written. This staging system, that is a communication language between or among oncologists and doctors. So, if we label T2, N1, M0, and type of cancer, so any oncologist anywhere will understand what does that mean, what is the condition of patient. So this is chest X-ray, simple chest X-ray. You can see these rounded bodies. These are metastases. This is ultrasound, and this is liver, and you can see these lesions. These are the mets in the liver. This is CT scanning showing mass in the left upper abdomen. Probably it is from stomach. This is MRI, magnetic resonance imaging. In this, radiation is not involved, and usually it is done for nervous tissue. This is spine, and you can see here this vertebral disc that has collapsed because of the tumor. This is bone scan. In those tumors which tend to spread to bones, we go for this, and especially in breast cancer. Over here you can see this is the injection site, just ignore it. And this is the urinary bladder where this, what they do is they infuse the patient with radio tracer. And after a few hours, when it has spread throughout the body, they take the scan. The gamma camera that picks the this radioactivity. And over here, you can see this is the sternum. There are hot spots. And this is femur. And the upper end has got hot spot. So these are the metastatic lesions. These metastatic lesions, they are hyperactive. They have osteoblastic activity in them. So that tracer is up, that is taken up more by this tumor cells than the normal tissue. So over here, that is anterior. This is the posterior side. There are so many uptakes or lesions in the spinal column. Then is a PET scan. Nowadays, this has become trendy, and it combines CT scan and PET scan. PET means positron emission tomography. The advantage is that it is very sensitive. This is the PET scan alone, and this is the CT scan. And when they are combined, they are fused, you can see the picture. Here you cannot see the architecture. Where is this lesion? But over here when you combine, so in this CT plus PET, you can see these glowing spots. They represent the disease. And this is how we interpret. We take a reference point and then we see standardized uptake value. So these are the tumor, and this is glowing, but this is normal. This is background noise. Similar over here, I have discussed that there is increased glucose uptake and advantage is taken. We use, because these tumors, they consume a lot of glucose, we use fluorodeoxyglucose. This is labeled with radioisotope fluorine, and when it is injected in the body, then these are short-lived isotopes. 10 to 15 minutes is the half-life when they are injected, and when they are taken up by the tumor, they emit, they decay, and as a result, positrons they are emitted, which will interact with the electron, and they will annihilate. When they annihilate, that means when they are destroyed, they release two photons in opposite directions. And here there are detectors which pick this signal, and they convert this signal into images. So this is the machine. PET scan is similar to CT scan or MRI. but it has got CT feature as well as gamma camera to click these photons. This is very sensitive, and for example, in breast cancer, we can use the indications are when the tumor size is 3, means more than 5 centimeter size, or when the axillary lymph nodes are clinically palpable, or there is suspicion of metastasis, or the tumor is of higher grade, grade 3, or triple negative. When these hormone receptors are negative, or inflammatory breast cancer, we go for it. Metastatic cancer of unknown primary, and in other situations, not only in breast cancer, if we treat and after completing the chemotherapy, for example, if we do the imaging and we found out there are lesions, but we don't know whether they are tumor or they are residual disease or they are fibrotic tissue. So to confirm that, PET scan is done and that will exclude the disease. Either that is tumor, in that case the tumor will be glowing. But if it is not glowing, means that is fibrotic tissue of no importance. It is also being used in infection to detect infection, hidden infection. These inflammatory cells, mast cells, neutrophils, they consume glucose. So this is a very good way of determining any hidden. In the patient, the fever is not subsiding, and there is no evidence where the infection is. So we can use this to find out the site of infection. So molecular classification that can be done by immunohistochemistry, fluorescent cytohybridization, DNA microarray, or PCR, the next generation sequence. This is the obsolete classification of breast. This is the molecular classification of breast cancer. This is luminal A, luminal B, HER2 enriched, or triple negative. This is this fifth one that is part of A. You just ignore that. This is the molecular classification for uterine carcinoma. We divide it into type 1 and type 2. Type 1 is more common and type 2 is less common. This is indolent and this is very aggressive. These are the genes which are involved. This is molecular classification for ovarian cancer. There are 5 main types. This is a molecular classification for CNS, central nervous system tumor. Now, tumor markers, you must have heard that in certain, for example, in ovaries, CA1 to 5 is the tumor marker. But tumor marker means it is a link to the tumor. If the tumor is growing, they will be at higher concentration. But this is CA1 to 5, and even others, they are not specific. Especially the CA15, which is very commonly done. It can occur in infection and during normal menstrual period. In cancer, it is high. Normal value is up to 35 international units. If it is more than 200, then one should take it as seriously. They help in diagnosing the disease, also monitoring. If you are giving treatment, it should come down. So we monitor after every cycle. And once it is done, during follow-up, we also conduct this test. If the cancer is relapsing, so this will start increasing. So this is important, and breast cancer is ERPR that and HER2, they are important. In liver cancer, alpha-fetoprotein is a marker we use. In germ cell tumors, alpha-fetoprotein and beta chorionic gonadotrophic hormone, they are important. Now, what is the prognostic? They determine behavior of the cancer as growth rate, risk of recurrence, metastatic potential, and survival of the patient. There are different types of prognostic factors. Residual disease size. In ovarian cancer, the main treatment is surgery. The objective is to remove completely the physical cancer. If ideally, it should not be more than 1 centimeter left for each deposit. If it is more, then that is not a good sign. So, the more is the residual disease, the poorer will be the prognosis. Then resection margin. You have taken out the cancer, for example, breast lump, hole. The margin should be clean. The surgeon should be expert that it removes the whole tumor along with some normal tissue, 2 centimeters of normal tissue. If when the sample goes to the pathologist and he sees under the microscope that there are cells, tumor cells at the margin, that is a bad sign. Normally we send back the patient to the surgeon to redo the surgery. So that is important. Histology. There are certain histological types which have good prognostic features and some are aggressive. For example, endometrioid cancer, it is slow growing and it has good prognosis. Clear cell cancer of ovaries, it is aggressive cancer. So when we know that this is aggressive, we can determine the prognosis. And serous type of uterine cancer, these are also aggressive type. Grade of the tumor. We divide it into 4, normally 3. Grade 1 means well differentiated, 2 intermediate, and 3 means poorly differentiated. Differentiated means well differentiated means the histopathological features are almost similar to the normal tissue, and grade 3 means they are distorted. Undifferentiated means there is no architecture. It is not possible to identify even the origin of tumor. Vascular invasion, when histopathology is done, pathologists examine under the microscope, and if any malignant cells is found in the lymphatics, or that means the tumor is it has already spread, though we don't know the metastatic site. So it is a bad sign. So we must consider that vascular invasion is there. Markers. This HER2 receptor, hormone receptors, P67, CA125. These are the markers. If HER2 is positive in breast cancer, it is a bad sign. Means the tumor is aggressive. Hormone receptor, if they are positive, that is a good sign. Because the tumor, they behave better than negative one. P67 means that they are surrogate marker for mitotic activity, cells in division. If it is low, that is a good sign. If it is high, means more cells are involved in proliferative activity. So less is good, high is bad. CA125 I have discussed. The lymph nodes involvement. In breast cancer, lymph node involvement is the most important prognostic factor. In ovary, residual disease was the most important. In breast, involvement of lymph nodes, that is the most important. And we consider that in the axilla. Up to 3 lymph nodes involvement, if there is no lymph node involvement, that is excellent. Up to 3, we are not aggressive. If more than 3 lymph nodes are involved, then means disease is advanced and we are aggressive. Stage. There are normally 4 stages. Stage 1, when the tumor is confined to the site of origin. 2 means when tumor has involved the adjacent tissue. And 3 means when it is locally advanced. And 4 means when it has metastasized to distant organs. Performance status I have discussed. It is the state of the patient. This is showing the, for example, this is lung cancer. If it is T1, T2, T3. So T1 is less than 3 centimeter, 2 is more than 3, and T3 it has spread beyond that. So if you see the T1 has better survival as compared to T3. Similarly over here, this is a skin cancer which is staged according to level of penetration. So the earlier will have good prognosis and the deeper one have poor prognosis. This is the lymph node in the breast cancer case. There is no lymph node percentage surviving. They are good prognosis. N1 the poor, then it will be N3 poorest. Over here, if combined with the size of the tumor and the lymph node involvement, if you see, if it is 2 centimeter size or less, and there is no lymph node, the survival is almost 90%. 1 to 3, it is 60%. If more than 4, it is further reduced to 40%. The same with the other sizes. Predictive factors, they determine response of tumor to therapy. For example, if the breast cancer has to be estrogen and progesterone receptor positive to respond to hormonal treatment. So if the tumor is ER positive or ER or PR positive, then only then we can give hormonal treatment. Otherwise, if in negative cases, there is no point of giving hormone. Similarly, in HER2 receptor positive cases, we can use trastuzumab therapy. This is a monoclonal antibody which attacks these hormone HER2 receptors. We consider this receptor as a switch, electrical switch. If it is on, it is producing signal for proliferation. If you turn it off by this drug, it will not. The cells will not grow; they will remain dormant. KRAS tumors are attracted to anti-EGFR agents. Now, if in lung cancer or in head and neck cancer, if KRAS gene is mutated, then there is no point of giving cetuximab or this pembrolizumab. Genetic signatures, they determine the benefit of chemotherapy. Now, there are assays which are commercially available, and if we do that, that will give us information whether we should use aggressive treatment or not. For example, oncotype DX and MAMAPRINT, these are two gene profiling assays. They determine recurrence risk over 10 years in early stage hormone positive, hormone receptor positive, HER2 negative, and up to 3 lymph nodes positive premenopausal breast cancer. Means premenopausal lady with breast cancer, early stage breast cancer, where up to 3 lymph nodes are positive, hormone receptors are positive. Should we give chemotherapy or not? That is the question. Chemotherapy has very toxic side effects. So this is a 21 gene PCR assay. It has got 16 oncogenes and 5 reference genes. If it is performed, the scoring will be either less than 11, more than 25, or in between. So if it is less than 11, then there will be no. This is all evidence-based. The studies the different trials have been conducted, and they found that there will be no benefit of adding chemotherapy if it is less than 11. If it is more than 20, yes, we should add chemotherapy. In between, they are irrevocable. There is no benefit in that. In 5 years, the benefit disease-free survival is 93%, 5 year overall survival 98%, and 9 year disease-free survival is 84%. So this is available, but this is expensive, and one can avoid giving chemotherapy in breast cancer patient, in early breast cancer patient. Now, how we plan the treatment? We treat cancer with different modalities. Say this is a cancer, we have surgery, we have radiotherapy, we have chemotherapy, the conventional chemotherapy which is toxic, notorious. Then we have endocrine therapy, which is very straightforward and without any toxic effects. Then is the targeted therapy. Targeted therapy is given by monoclonal antibody or small molecule inhibitors. And here we target specific molecules in cancer. Then is immunotherapy. This immunotherapy has revolutionized the oncology practice over the last 10-15 years. And this is being used in most of the cancers. Then there is tumor agnostic therapy. This is also interesting for the last few years. पहले पेशेंट आते थे कहते थे कि कोई ऐसी ड्रग नहीं है जो हम सारे कैंसर में यूज करें. This is something like that, right? When I discuss it, so this is interesting. Then, if all these modalities we have used, or whatever we have planned and we have used that, and that cancer is not responding, you diagnose, you plan treatment, you start treatment. You control the cancer and then follow up. Then you follow up. The purpose is to know when it has re-emerged or relapsed. When it relapses, you again give a treatment. Then it will go again in remission. Again you follow up. So depending on the type of cancer, there will be either one relapse or there will be multiple relapses. So once you have exhausted with everything and you see that the tumor is growing, then you think about clinical trials. You check if any clinical trial is going on anywhere for a patient where this particular patient can fit into that. So the only condition is that the life expectancy should be at least 3 months. Patient इतना आ गया, उसकी 3 months की life expectancy है, और उसका performance status भी 2 तक है, 2 or 3. Then the patient can be entered into that trial. Then the best supportive care means there is no specific treatment. You just relieve the symptom. If patient is having pain, you give painkiller. You normally give opioids, morphine. We have pharmaceutical preparations, and that is the best painkiller. If patient is having vomiting, you just give antiemetics. So it's symptomatic treatment. And the last, we do nothing right from the beginning. So this is another modality. You have diagnosed the case, the cancer, but you have decided not to treat. Wait and watch. And these are those cancers which are very slow growing and they are asymptomatic. Right? Prostate cancer is one example. You know that the patient is having prostate cancer, but there is no symptom. It is not causing any problem. So we will wait. I'm talking about advanced prostate cancer. In early, we do intervene, but in advanced, patient present with advanced prostate cancer, but the symptoms are not that great, and patient can live with as such without any treatment. So we keep the weapons which we have got till time when patient develops cancer symptoms. So एक चीज़ है आपके पास और तो मोडेलिटी नहीं है क्योंकि एडवांस कैंसर में इसकी जो effectiveness है वो that is limited. So keep the drug for a time when patient is having problems. Another situation where we follow this wait and watch is those cancers which are rare. Rare cancers, we don't know much information and we don't have effective or evidence-based treatments, because those rare cancers is not easy to conduct trials. तो उसमें भी हम लोग देखते हैं कि अगर उसमें कोई पेशेंट को सिम्टम्स वगैरह नहीं है, we don't do anything. We just wait till it starts giving problem. In the tumor board, how we plan? We consider there are factors related to the patient and those with the tumor. Age, older age, we have to consider their tolerance because they tolerate chemotherapy poorly. Gender, there's certain cancers where men they tolerate better than women. Comorbidity, having heart problem, one has to consider performance status, reproductive stage, whether the patient is premenopausal or postmenopausal, socio-economic status, whether the patient can afford treatment, whether one should go for these novel treatment which cost in lakhs or in millions. Emotional status of the patient, that is also important. On the other side, tumor side, where it is located, what is the histological type, what is the molecular class, stage, prognostic and predictive factors, right? Up to now, things were generalized. But if we do the gene profiling and we come across variants which are very unique, then we'll try to plan a specific treatment for them, and that is personalized treatment. अगर इस तरह की कोई चीज़ आ जाते हैं, this is not done commonly, even in America or in Europe. There are selective centers which are performing these assays, and if they come across any particular gene, then they plan. It's not easy for a clinician to interpret the data. It's the same thing. So I will take it when I talk about this agnostic therapy and other. So, basically, if you do the gene profiling and you come across any particular gene which is mutated, then there are knowledge base or database available. You go online and you check that for this particular mutant gene which is being expressed in this particular patient, is there any medicine? So they will guide you. So उसका एक पूरा है, I will discuss later कि how you, there are 5 levels. या तो है कि हाँ भी पहले इस किस्म के ट्यूमर हैं जिसमें ये जीन देखी गई है, so we will use the same drug which was used for that particular set of patients. So this is for today. If there is any question, I understand this was quite boring. But when I take individuals, I think that will be interesting. There is a lot of information which I had to cover in this short time. A question on the question?
So in a Western world, women use alcohol that I put more than us as a Pakistani woman.
Yeah.
So why here is so high the level of cancer, breast cancer in Pakistan rather than that? Logically, they are most probably have